All right, good afternoon, everyone. My name is Maeve Williams, and I am a project manager at the North Dakota State University Center for Immunization Research and Education. Today, I have the pleasure to introduce Dr. Elizabeth Skoy, who will be presenting this webinar titled Adult Vaccine Conversations, Addressing Common Concerns. Dr. Skoy is a professor at NDSU and the director of the Center for Collaboration and Advancement in Pharmacy, or the CAP Center. As part of her faculty position, she has a community pharmacy practice site where she continues to engage in routine pharmacy patient care. Dr. Skoy has represented the pharmacy profession through various agencies, including the FDA, CDC, and the American Pharmacist Association. Most recently, Dr. Skoy was named to serve on the Advisory Committee on Immunization Practices, or ACIP, work group for adult RSV vaccines. Dr. Skoy, you can begin.
Thanks so much, Maeve, and thanks everybody for joining in this webinar today, titled Adult Vaccine Conversations Addressing Common Concerns. So we'll go through some of our housekeeping slides here first. So this is the disclosures if you're seeking CME and or MOC credit, as well as the disclosures if you're seeking pharmacy continuing education credit. And I do not have any relevant financial relationships to disclose today. Okay, Maeve already gave a great introduction, so I'm going to skip over this slide and we'll just talk a little bit overview of what we're going to be discussing today. So the first thing is we're going to identify common questions and concerns adults have about routine and seasonal vaccines. We're going to be covering both of those. We're also going to talk about some communication strategies for discussing adult vaccines with patients and also explaining the role of the healthcare provider in initiating and navigating vaccine-related conversations with adult patients confidently. So here, as I was kind of kick things off here, here's the schedule for adults, the adult vaccine schedule from the CDC. And you're going to notice here that our schedule has really expanded over the last few years. So as where you usually saw, pneumonia, every 10 years, your tetanus, some of those now we're seeing more vaccines being added onto the schedule. And sometimes it can be a little, if you're comparing the adult vaccine schedule potentially to the pediatric vaccine schedule, there can be a little bit more ambiguity sometimes with that because it will be more risk-based sometimes as to the recommendations that you're providing, as well as there's even some shared clinical decision making that can be involved with some of these vaccines. And so we're going to be talking a little bit about some ways to navigate and understand the schedule, as well as to have those conversations with our patients to make some strong recommendations. So to tee this up, I think it's important for us to understand what our patients find valuable when getting a vaccine recommendation. And so if you look at the bar graph here, the blue lines or the blue bar graphs are patients' perspectives, and then the orangish, yellowish are healthcare professionals' perspective. And so when asking healthcare professionals and patients their perspective on what motivates older adults to get vaccinated, there's quite a bit of a discrepancy between what we think as healthcare professionals motivates individuals, as well as the individuals themselves say that motivate them. And so looking at what actually motivates people is really that strong recommendation from the healthcare professional. And also, learning more about the vaccine, but really, the ability to get the vaccine in the healthcare professional's office or, family and friends supporting their decision, and even transportation really isn't that important to them. However, healthcare professionals, sometimes we undermine our opinion and our recommendations healthcare professional or to our patients, as well as sometimes we think that their ability to get that vaccine at the facility that particular day is incredibly important. And really, you're seeing that when you're asking patients, it's not as important as we sometimes think that is. So I think what this really gives us as a good perspective to tee it up is that our recommendation really matters, as well as even if you don't have the vaccine available to you at the clinic, at the pharmacy that particular day, that you still can make that recommendation, and them not necessarily being able to get it that exact same day is always as influential as we might think it is. So overall, our recommendation as healthcare professionals really does matter. We are still the most trusted source of advice and information when it comes to vaccines, despite what we might think and some of the noise that we hear from the media and social media. We still are the number one trusted source for this. And over 83% of patients and caregivers really cite doctors and healthcare professionals and providers as that trusted source of information. So we're still on top, we're still the experts, and we're still who our patients are listening to overall. So, when we're making these recommendations to our patients, there's some communication strategies that we can implement. And really, the best recommendation is to start with a presumptive approach. And so that presumptive approach is not as much of a participatory approach. So we think of a participatory, it's getting the patient's feedback. So how do you think about getting this vaccine today? Or, today it's time for your seasonal influenza vaccine. What are your thoughts about that? Would you think that you want the vaccine? That's more participatory. But a presumptive is a strong recommendation. So that's when we come in and we say, today you're here for your appointment, and it is also time for you to get your seasonal influenza vaccine. I see that you haven't gotten that yet, so we can get that prepared for you right now. So that presumptive approach, assuming that the patient is going to accept the vaccination and go along with vaccination, is the standard that we want to go by. Then, if there is some hesitancy, if the patient, is a little resistant to vaccination or shows some of that hesitancy, then we can go to the next approach, which is that motivational interviewing. And motivational interviewing is more of that patient-centered approach. We're usually asking our patient open-ended question. We're asking permission to provide information. We're listening, active listening, engagement with the conversation, reflecting back to what they're saying, and we're honoring the fact that they may not necessarily agree with our recommendation. And if the patient, despite that motivational interviewing, still declines, we still have to focus on building trust with them. And so we want to maintain that healthy relationship with our patients and tell us that we value their decision. And although we might disagree with it, we're still going to continue to have this conversation and see if there is anything else that we can do in the future to continue to make these vaccine recommendations for them. And I also think that it's important for us as facilities, clinics, hospitals, pharmacies, wherever it is that we're working, public health units, to build that confidence within our own individual people. And so I think it's important that we provide opportunities for those that we work with to learn about vaccines, like those of you that are participating today, which is great. Also discussing any concerns and being educated on how to have those conversations with our patients. With our patients, we want to also create a safe place where our patients feel like they can ask questions and that we can offer our own knowledge to not only our colleagues, but also our patients. And this can really foster a culture of immunization within our own facilities. And so, it kind of starts with us, right? So, we want to enforce those best practices, making sure that we ourselves are also getting vaccinated and encouraging our colleagues to have that conversation with our patients and using that saying, every patient, every encounter. So, every patient, every encounter, ensuring our patients are up to date with their immunizations and making those recommendations. So, we're going to pause just for a moment to do a quick knowledge check. You don't necessarily have to put your answer in the chat or anything like that. We're just going to have you can think about the answer to yourself. So, what is the most effective strategy healthcare professionals can use to motivate older adults to get vaccinated? Option A, a strong recommendation by the healthcare provider. B, provide information on the vaccine preventable disease. C, provide the vaccine during that office visit. Or D, drive them to get their vaccine. And our answer is A. So that again, from that poll that just came out in 2025 this year, looking that it is a strong recommendation from the healthcare provider that motivates older adults to get vaccinated. So now we're going to get into some of our more common questions that we sometimes get from adults for vaccination. So the first one is vaccination after infection shingles. And before we kind of launch into the answer with this, we're going to go through a case study with you. And Maeve is going to be playing the role of the patient, and I'm going to be playing the role of the healthcare provider. And she's going to be using her normal voice. We're not going to mimic voices or anything like that, but it can demonstrate to you what an encounter might look like. So Maeve, thanks for joining. And today, we're going to be assuming that Maeve is John. They're a 50-year-old patient. Flu and Tdap are recorded at their last annual checkup, and they recently received their COVID vaccine at their local pharmacy. So the reason that our patient is here today is they're getting their annual physical at a local VA hospital. And the other health information is they're hypertensive and they also have high blood pressure and they have high cholesterol. So we're going to have just kind of role play this case for you. So, hi, John. It looks like you're caught up on all your vaccines except for the shingles vaccine. Since you're 50 now, I'd like to take care of that today. Unless you have any questions, we'll go ahead and get that ready for you, and then you'll be on your way.
Well, I've actually already had shingles, so I shouldn't need the vaccine.
Oh, so although you've already had shingles, it is still important for you to get vaccinated. Can I share some additional information about why I think it's important for you to get vaccinated?
Sure.
Okay. Thank you so much, Babe. And so before we get into a little bit about the shingles vaccine and answering this question for our patient, just here note that for this particular individual in this conversation I had with them, I first started with that presumptive approach, right? I said, okay, now that you're 50 years old, it's time for you to get your shingles vaccine. And then when my patient showed a little bit of hesitancy and said, oh, I don't think I actually need that vaccine, then I asked to share some additional information with them. So, kind of going back to those communication techniques that we already talked about. So we're going to just do a quick overview of shingles. So shingles is caused by the dormant virus herpes zoster that can reside in our body after initial exposure. And this can be when we actually have this virus reappear, it can lead to shingles, which is an itchy, sometimes very painful rash. And it's usually either on the left or the right hand side of the body. And this usually will develop in some blistering that usually scabs over in about 7 to 10 days and usually will completely go away after a few weeks. So, people who have already had chickenpox are at risk of developing shingles. However, most Americans that were born before 1980 at some point have had chickenpox or been exposed to chickenpox in their lifetime. And so, they're again, thinking of our current older adult population that would qualify in this group. And it's estimated that 1 million people each year get a shingles infection in the United States. Some other things to consider with the shingles infection and where this really comes down to what you're trying to prevent is this postherpetic neuralgia, or also known as PHN. So this can be long-term nerve pain that occurs where that shingles rash was located, and this can last for a couple of months, but even can last for years. And it's anywhere between 10 to 18% of individuals will also experience this PHN. And our older population, our older adults are at most at risk for this. Also to note that the shingles infection can also cause vision loss and can also have it cause a secondary bacterial infection from the rash itself. And then there's also some more rare side effects that can occur from the shingles infection. So there is a vaccine that's currently available in the United States, the recombinant zoster vaccine, or Shingrix, as we refer, or as the brand name for that. It's recommended for adults 50 years and older. This age range, so is was lowered a couple years ago, so it's 50 years and older for everyone. But also, if there's adults that are 19 years and older that are immunocompromised, would also qualify and be recommended to have the Shingrix vaccine. The vaccine is given 2 doses, which are 2 to 6 months apart. And you usually want to avoid actually vaccinating an individual if they're in a current outbreak of a shingles infection or if they're currently taking any antiviral medication. But it's also important to note that you should still vaccinate individuals who have already had shingles in order to reduce the risk of future attacks. So it's about 4% of the population can have another outbreak, even if they've already had the shingles vaccine or the shingles infection naturally. And so it's really important to note also that if a patient has also received the Zostavax vaccine, which is a vaccine for shingles, which is no longer available on the market, but was available, was a live vaccine, was available a few years ago now. If they had that, they still should now get the Shingrix vaccine. And so it's always important to look at the individual's age, and then, of course, if they're immunocompromised, 19 years and older as well. It's also important to note that the shingles vaccine does cause a really strong immune response. And so there can be some side effects with this vaccine. So the patient can have a sore arm, maybe redness and swelling at the injection site. These side effects from the vaccine usually last about only 2 to 3 days and will usually just go away after that. And then it is more common in the younger ages when you provide the vaccine. However, although there are some side effects with the vaccine, so it's important to educate our patients on that. The vaccine is really effective at preventing shingles and PHN. So if you're looking at that adults 50 to 69, we're seeing that 97% for preventing shingles, 91% for PHN. It drops a little bit when we vaccinate individuals 70 and older, but still a really high effectiveness for the vaccine. And then for those that have a weakened immune system, it varies depending on the condition of their current immune system, because as we know, immunocompromise can really vary from one individual to another, but still effective at preventing shingles as well as PHN. So we're going to go back to our, okay, so now I've provided some information to you that you could provide to your patient. We're going to go back. So I've asked permission, if you kind of think back to a couple slides ago, I asked permission to provide some information to my patient. So now we'll continue with that. So the shingles vaccine can prevent future reoccurrences of shingles. 2 doses of the Shingrix vaccine given to adults 50 to 69 years old have been found to be 97% effective at preventing shingles and 91% effective at preventing the most common complications of shingles, that post-therapeutic neuralgia or long-term nerve pain, as we sometimes refer to it. So getting vaccinated is the best way to protect you from developing shingles again and in the future. Do you have any questions about that?
No, that makes sense. I don't want to get shingles again. That was really brutal. If you think it's a good idea, I'll go ahead and get it.
Yes, I highly recommend the shingles vaccine to all of my eligible patients, and I think you're making a great choice for your health. So I'll go ahead and get that ready. So as you see there, I'd asked permission to provide some education. I did that, and then asked, if they had any questions on that and their thoughts about getting vaccinated, and it ended up in the patient getting vaccinated. So now we're going to go into another knowledge check. And again, you don't necessarily have to answer, but just kind of thinking to yourself. So true or false, adults who have already had shingles do not need to receive the shingles vaccine. And again, that is false. So again, even if someone has had shingles, they are still recommended to receive the shingles vaccine to help prevent future occurrences. All right, so now we're going to go into another topic that comes up a lot in conversations with patients, and that's approved versus recommended. And we're going to talk about specifically, we've seen this within the last year with the RSV vaccine. So we're going to just launch right away into another case, our second case here. So this case is for a 55-year-old patient, and they have no history of risk factors, and they're caught up with their immunizations. They've already received their seasonal influenza and COVID vaccine. And this particular patient, though, does stay home with their 3-month-old grandson sometimes. So with that, we're going to launch into this and I think we're starting off with our patient today. So go ahead.
Hey, before I forget, I wanted to ask about the RSV vaccine. I heard the FDA approved one for adults over 50, and I've been thinking about getting it.
Sure, I'm glad you brought it up. What have you been thinking about?
Well, I help take care of my grandson a few days a week, and he's only 3 months old. I'd hate to be the one to bring something home to him, especially with RSV being so dangerous for babies.
I definitely understand and appreciate your willingness to protect your grandson. Do you mind if I share some information with you about the RSV vaccine for adults?
Please do.
Okay. So now we are going to talk about this next topic, RSV and older adults. So overall, RSV is a respiratory infection, and for most adults, infection is usually mild. So symptoms generally are limited to what you would see with other upper respiratory tract infections. So runny nose, sore throat, cough, headache, fatigue, fever. And for most people, those symptoms will usually just resolve themselves in 1 to 2 weeks. However, particularly for patients that are 60 years and older, this can lead to other serious health conditions. And so RSV, although we've historically kind of thought of RSV as a disease for infants and the very young children, which is true. It's still a very deadly disease for those. It's actually also a deadly disease for our older adult population. So it's estimated that anywhere between 100 to 150,000 adults 60 plus years old in the US are hospitalized each year. And it's also thought that this number could potentially be even underreported because vaccine or not vaccine, screening for RSV isn't always commonly done routinely. And so it's estimated that the number of infections could potentially even be higher than that. And complications from RSV can arise to pneumonia, and it can even result in hospitalization and potentially even death from RSV. And particularly those that are have COPD or congestive heart failure, asthma, are just some of the examples who are at highest risk for individuals with a severe RSV infection. So the good news is there is an RSV vaccine available. And it is recommended currently by the ACIP for all adults ages 75 and older. And so that's just kind of a blanket recommendation. So everyone 75 and older should receive 1 dose of RSV vaccine. But it's also recommended for adults 60 to 74 who are at risk for severe RSV disease. And so that's not that blanket recommendation, right? We're thinking of 75, everyone 75, but only for particular adults 60 to 74. And we're going to see that here. And so risk factors associated are listed here. So anyone with like chronic lung disease, cardiovascular disease, liver disease, progressive neuromuscular and neurological conditions, hematologic conditions, end-stage regional or renal disease, that's particularly, or if they're dependent on dialysis, are at high risk. Diabetes mellitus with end organ damage, or those that require insulin or SGLT2 inhibitors. So again, you're not looking at everyone that has diabetes, but those that are, more complicated cases. Moderate, severe immunocompromised, and then severe obesity with a greater BMI, and anyone that is residing in a nursing home. And that's not a nursing home means like a skilled care facility. That's not necessarily like a retirement community. It's actually more of a skilled nursing facility. And so that is the current recommendation from the ACIP. Now, there is a very important asterisk at the bottom of this slide that I do need to bring attention to. So in April of 2025, so a little less than a month ago, the ACIP did meet, and they have expanded the recommendation from 60 to 74 down to 50. So 50 and also 50 to 59 that are at an increased risk for severe disease. However, although the ACIP has recommended this, it has not yet been fully adopted by the CDC. So at this time, it's not been fully adopted, so we're not implementing that quite yet. But at any time, that could change, where we're decreasing that age down to 50. But I do think it's important to note because we're going to see some FDA approved uses that sometimes differ from the ACIP recommendation. So if you're looking, so if you look here, so at the very top row, you have the FDA approved uses. And so we have 60 plus for everybody, and then ages 50 to 59 approved for GSK with increased risk, and then Pfizer goes down 18 to 59 with increased risk. Okay, and then you have Moderna. That's still at 60 plus, although they are looking to seek application to lower their age threshold as well as approved from the FDA. So sometimes what's approved by the FDA does differ from the ACIP. And so you're looking here, the ACIP recommendations do differ that from what's been approved by the FDA. So sometimes you'll hear, this vaccine has been approved. Yes, it's been approved by the FDA, but that doesn't necessarily mean that that's been what's recommended by the ACIP and CDC for implication. Also, looking at just overall, it's good to also note the effectiveness of these vaccines. So the RSV vaccine is, effective at reducing emergency department visits and hospitalizations. Particularly, we've seen that with the GSK and the Pfizer vaccine, the Rexv and Abrysvo. The Moderna's Mrezvio vaccine, they did their studies a little bit differently, and so they looked more at lower respiratory tract signs, symptoms, as well as acute respiratory disease, but still effective at preventing those as well. And right now, the length of protection is not known. So studies are kind of ongoing with that, but we are seeing at least 18 months to a couple of years currently for length of protection from the vaccines. So, also important to note that it has, has come that there is some risk of GBS or Guillain-Barré syndrome with the RSV vaccine. Particularly, we've seen with some risk with the Abrysvo vaccine as well as the Rexv vaccine. And when you're looking at that, though, it's also important to note that there's 0 to potentially 18 cases of GBS per a million people vaccinated. So if that means if you vaccinate a million people, you could have up to 18 of these cases. But then if you're also looking, though, at the incident of prevention of hospitalizations, ICU, and then deaths, it has been determined that the benefits of vaccine far outweigh the risk of potential GBS. And you're really especially seeing that you're looking at this age group, that's 75 plus, the number of prevention of hospitalizations, ICU admissions and deaths, and also same with that 60 to 74. Goes down a little bit with 50 to 59, but still is seeing some really good protection there. So again, benefits of vaccine really do outweigh those risks of GBS currently from the data that we have. And so also, although the RSV vaccine is not currently an annual vaccine, it's also important to note that there are studies that are kind of ongoing for how long the current one dose will be protecting. And so just note that although right now it's one dose and you're done, that could potentially change in the future. But sometimes people think that since this is a respiratory vaccine to prevent a respiratory tract infection, that it's a seasonal, right? So, COVID, usually get it annually, influenza annually. And so people sometimes think, well, I need to have an RSV vaccine annually. And just remember that it's only a one-time dose at this time for RSV prevention. So now we will move on to our case. So we've already started this conversation. So right now, the RSV vaccine is recommended for adults 75 and older and adults 60 to 74 at increased risk of severe RSV. There is also a recommendation for adults 50 to 59 at increased risk, but that's still being discussed. Since you're 55 and otherwise healthy, it's not routinely recommended for you right now.
Even if I just want to protect my grandson?
That's a really good question. The way the vaccine works is mainly to protect the person who is actually getting the vaccine rather than preventing the spread to others. So it wouldn't really give your grandson that direct protection. It's different from something like whooping cough or Tdap vaccine, where we do recommend adults get it to create a cocoon of protection around that newborn.
Okay, so it wouldn't really help him much if I got it.
Probably not in a meaningful way, no. What's more effective is being really mindful of hygiene. So washing your hands, not visiting your family members, your grandson if you feel sick, and limiting close contact during that cold season if you're under the weather. Also, the pediatrician may have talked with your grandson's parents about options like maternal RSV vaccination during pregnancy or the antibody shot for infants, which is what really gives that baby that direct protection.
Got it. I just want to make sure that I'm doing everything I can.
Oh, and you are. Asking about this shows how seriously you take it, which is great. If guidelines ever change or if you develop any health conditions that put you at a higher risk, we can definitely revisit it then.
Sounds good. Thanks for explaining all of that. It can get so confusing.
All right. So that's kind of an example, and I've actually had quite a few of these conversations with patients who want to get the RSV vaccine, but once you've educated them that they're just if they're not at that risk to receive the vaccine and they don't have those at-risk health conditions, that vaccine just isn't really made for them at this particular point in time. All right, so now we're going to talk about shared clinical decision making and particularly focusing on the HPV vaccine. All right, so we're going to launch right into another case for this. This patient is 29 years old, and per their records, they've never received the HPV vaccine. And we also found out from our visit with them that they've had a change in relationship and they have recently broken up with their boyfriend that they've had since high school. So, okay, it looks like you're up to date on most of your vaccines. Since we discussed your change in relationship status, I want to ask, have you ever had the HPV vaccine?
No, I don't think I did. I was with my high school boyfriend for so long and it just never really came up.
Oh, that's good to know. And thank you for sharing that. We usually give it to those in their teens or early 20s, but for adults ages 27 to 45, like yourself, we could still consider it based on your individual risk and your preferences.
Okay, is it still worth getting it now?
So before we get to this case, we're going to provide a little information on the HPV vaccine for adults. So, sharing clinical decision making, or what has sometimes we called SCDM, is recommended for adults 27 to 45 who have not received the HPV vaccine. So, we're talking again about individuals who had not been previously vaccinated that are in this age group. It's also important to note that this is not a vaccination that needs to be discussed routinely with all adults in this age group. HPV vaccination prevents new HPV infection, and it's not used to treat like an actual current HPV infection or disease. So vaccine effectiveness is the highest in people who have either never had sex or most adults who have had sex but with the same person and haven't had any changes in exposure to HPV. So those adults with those fewer risk factors, again, either had no previous sexual partners or very few previous sexual partners, might not have been infected with HPV, but if they have a change in their relationship status or change in their circumstances, meaning that they might have you know different or new sexual partners in the future, they could potentially be a candidate for the HPV vaccine. So we are going to review back to our case with our patient. All right, so it can be the vaccine protects against certain strains of HPV that cause cervical cancer and genital warts. It works best before someone's exposed to the virus, but even if you've been sexually active, it may still offer protection against types that you have not yet encountered. Since you're newly single, if you think that you might be dating or starting new relationships in the future, the vaccine could give you some added protection going forward.
Yeah, honestly, it's been a weird adjustment after so many years, but I guess dating again might be in the cards eventually.
That makes sense. It's been a big transition and it's smart to be thinking ahead. The vaccine is very safe, and some people in your situation choose to get it just for that added peace of mind. It's up to you what you're comfortable with.
Okay, yeah, I like the idea of getting ahead of it instead of waiting and wondering later.
I think that's a really great mindset. Since you're 29, you need 3 doses of the vaccine spaced out over 6 months. If you're ready, we can start the first dose today.
Let's do it. Might as well check it off the list.
Sounds good. We'll go ahead and get that ready for you, and then we're going to schedule your next 2 doses in the future. All right, so this is a really, I think, a good example, really great example of how shared clinical decision making should be, is to identifying somebody who could benefit from the vaccine, discussing the risks and benefits of vaccination with them, and then having that really that conversation as to what the patient and you think are best for them together. Also note that I've had a few conversations like this, either people who have gotten out of long-term relationships or individuals who maybe have gotten divorced and then are going to start dating or they think they might start dating in the future. So, this is a really great example and case example of when that shared clinical decision making for that age range could come into effect for the HPV vaccine. All right, so now we're going to get into our next topic, which also we get a lot of questions about. So, co administration and vaccine necessity. COVID-19 and RSV is the case that we're going to go through today. So I'll have my patient come back up here. So this patient that we're visiting today is 81 years old. They're up to date on all of their vaccines based off of our last visit about a year ago, and they are going to be admitted into the nursing home, and so they're having a pre-admission physical with us. And the patient's name is Jennifer. All right, Jennifer, we're almost done with your physical to get you admitted to the nursing home. It looks like you've already had your flu shot, but before you go, we'd like to vaccinate you against RSV and COVID-19 today. Do you have any questions?
I'm not really sure about getting another COVID vaccine, especially at the same time as the RSV one. I already got a COVID shot in October, and I just don't think I need another one.
Oh, I've heard some similar concerns from a lot of my patients. Would it be okay if I provide some information on why I think it's important for you?
That's fine, but I'm not sure that it will change my thoughts.
That's okay. If I just want to make sure that you have all of the information you need to make an informed decision. Okay. So there again, highlighting the presumptive approach, right? We started with, okay, it's time to get your vaccines, and this is what we're due today. Patients showing a little bit of hesitancy, and so we're going to be having more of that motivational interviewing approach where I ask for some permission to provide some information to them. So, we're going to provide a little background and updated information on adults and COVID-19 vaccine. So, our adults 65 and older comprise more than 2/3 of all COVID-19 associated hospitalizations. So, really, that 65 and older is the most at risk group that we have. And 1 in 5 adults hospitalized, so once you're hospitalized, 1 in 5 of those end up being admitted to the ICU. And during that same period that we looked at, so looking at this particular graph here, from 24 to 2025, 80% of all adults that were hospitalized with COVID-19 who died in the hospital were 65 plus. So there again, highlighting that not only are that 65 plus group highest at risk for hospitalization, ICU, but also for death. And most of the adults that were hospitalized had not received a COVID-19 vaccine since September of 2022. So looking also at some additional information. So this is COVID-19 deaths by age from January 2020 to February 2025. And if you look at this bar graph, it's actually astounding, right? So you're seeing that 18 to 29 is a really low percentage, but once you hit that 65 plus, and especially that 75 plus, the deaths by age really increase. So again, more than 81% of COVID-19 deaths occur in people that are over the age of 65. And that number of deaths is 97 times higher than those 18 to 29. So again, looking at the far left to the far right, we're looking at a 97 times higher, which is a crazy number if you really think about that, is how higher at risk our older adults are for COVID-19. And particularly of those adults that are currently in community living, or particularly nursing homes, only 30% of the patients living in nursing homes have received the COVID-19 vaccine 2024 to 2025. And this was as of October of 10th of 2024. And so, if you think of those that are typically in nursing homes, usually they also have underlying health conditions and medical conditions. And this, again, is that greatest risk. Not only that 65 plus and those older adults, but individuals that also have underlying medical conditions that are at that higher risk. Now, you might be thinking, well, Jennifer is having a pre-admission visit, but it's already May, and aren't we done with the seasonal respiratory infection? And this graph is a good reminder that usually we see a second wave of COVID-19. So we're usually seeing a winter wave, and then we also usually see some sort of a summer peak. And so when we're comparing that, COVID-19 is the red line on this graph. So you're going to see that peak somewhere around January. And then you're going to see another one that comes later the next year in August. We don't really see that with our other infections. So if you look at RSV and COVID-19, they usually stay to those winter time frames, whereas we do see usually as we call the second wave or the summer wave with COVID-19, where we're seeing a spike of infections usually between the months of July and September. So again, important to make sure that our older population, if they hadn't received one in the fall, they still should be getting vaccinated. So our current COVID-19 vaccine recommendations, that the CDC recommends that everyone currently aged 6 months and older receive one dose of the 2024-2025 COVID-19 vaccine. Adults 65 and older, again, that's our group that's at the greatest risk, should receive 2 doses of vaccine that are spaced 6 months apart, as well as individuals who are immunocompromised. And co-administration is, with other vaccines, is safe and effective. And additional considerations for COVID-19, particularly and the Mpox vaccine, co-administration may need to be concerned, but for the most part, other vaccines right now are co-administration is acceptable. It's also important to note that these are the current recommendations. However, some of these recommendations may change when the ACIP meets again in June. It's predicted that they're going to reevaluate the COVID-19 vaccine recommendations. So be looking for any updates that might be coming from that. So COVID-19 and preventing complications. So studies have shown that the mRNA COVID-19 vaccine provides benefits in preventing long COVID. So we're not only talking about the current COVID infection and preventing a current infection, but we're also talking about how vaccine has been shown to prevent complications from COVID infection that we refer to as long COVID. So there's a 70% decline in long COVID cases from the pre-Delta to the Omicron eras attributed to vaccination. And so 3 doses of original monovalent vaccine prior to infection is associated with reduced likelihood of that long COVID symptoms in adults. So you're seeing a marked decrease in gastrointestinal, neurological, and other those kind of blanketed long COVID symptoms. And the bivalent, particularly once we went to that bivalent, the 22 to 2023 started then adding that protection against thromboembolic events compared to receiving only the original monovalent vaccine. So we could see this, for a couple of different reasons as to why this might be. But again, the COVID-19 vaccine is preventing potentially like a more severe infection, as well as they're preventing if you're preventing the actual infection itself from occurring, you're also going to be preventing that long COVID. All right, so if you remember from the last time that we ended our conversation, I asked if I could provide some information for them. So I'll go back to that. So because of your age and your new living situation, you're at a higher risk of being exposed and getting very sick from COVID. In fact, most people hospitalized with COVID last year were older adults, such as yourself. We recommend individuals over 65 get 2 doses of the COVID vaccine, spaced out 6 months apart, so that those that are most at risk of getting very sick all have protection that they need. We've also seen a trend in the midsummer waves of COVID infections, so that extra dose may provide that additional protection for you during that time. And it's also likely, we'd also like you to get vaccinated for the RSV vaccine today, as that can also cause serious problems for older adults. That vaccine is also safe and effective and it's safe and effective to get both of these vaccines at the same time. And actually getting them today will make sure that you're protected as early as possible. Some people may feel a little achy or have a low fever after vaccination, but those symptoms usually go away pretty quickly in a day or two. Do you have any other questions about that?
I appreciate the information, but I just don't know about getting them both today. It still makes me really nervous.
That's understandable. And ultimately, this is your decision. On a scale of 1 to 10, how confident are you getting vaccinated against RSV and COVID today?
I'd say 5. Honestly, I'm okay with receiving them both based on the information you provided, but just not at the same time.
Oh, it's great to hear that you're open to both of them. So you said you're at a 5. What would it take for you to get to a 6 or 7?
Maybe just getting the RSV shot today and then doing COVID another time.
Yep, sure, we can do that. I'll get the RSV vaccine ready today, and then we'll get you scheduled to come back for the COVID shot before you go.
Thank you. I think that will make me feel more comfortable.
Okay, and so kind of just summarizing that particular encounter that we have here with this patient, going back to we're utilizing that motivational interviewing, we actually asked them to provide a rating on a scale of 1 to 10, how comfortable they are. And when they were only at a 5, we said, well, what could it take to get you to that 6 or 7? And when they told us that, we kind of met kind of in the middle there. It's also important to note that co-administration, when they looked at the data, what we've seen, there's been a lot of co-administration with the RSV vaccine. Thinking about that, people are coming in for their influenza, their COVID, and then if they're that age, getting that one dose of that RSV vaccine. And so that's become, we look at the data, a lot of those, it's very common to have multiple vaccines given at the same time. There have been some studies that have shown that RSV vaccine, when given with COVID and or influenza, may see a little bit of a dip in the antibody titers that are coming from vaccination. However, the clinical significance of that dip is yet to be understood or unknown. And so co-administration of vaccines is usually recommended. So it's a pretty strong, usually blanket from the CDC that co-administration of vaccines is recommended. With RSV vaccine and co-administration, the terminology they're currently using is acceptable. So it is acceptable. However, if you have a patient that so this individual wants them separate, and or if you have a patient that is going to be coming back in, they're regularly in the pharmacy or they're regularly in the clinic, and they're going to come in and get that dose, then it is also acceptable to space those two vaccines out. So things to kind of consider as to when to recommend having co-administration, or allowing those patients, or I shouldn't say allowing, but being a little bit more comfortable, I would say, with separating those out, are if they're up to date with their other vaccinations, again, how frequently and easily they can get to you to get the other ones, and feasibility of that happening, and also looking at their risk for disease. If this individual is going to be going into a nursing home shortly, which is going to put them a little bit more at risk, but again, if they're, it's going to make them more comfortable for having those spaced out, and we know we can get them those vaccines, that's perfectly acceptable as well. All right, so now we're going to be getting to our last topic today, which is necessity and effectiveness of flu vaccine. So as usual, we're going to start off with a case. So this is Mark, and Mark is a 40-year-old patient that's coming to the pharmacy today. So hi again, Mark. Looks like we've got your blood pressure and cholesterol medications ready. While you're here, just a quick reminder that we're offering flu shots here at the pharmacy.
Yeah, I think I'll skip that this year.
Okay, out of curiosity, do you mind if I ask why?
Well, honestly, every time I've gotten the flu shot, I've still ended up getting sick that same season. Just seems like it doesn't make much of a difference for me.
I understand why it can feel like that sometimes. Do you mind if I share some more information about the flu shot and why I'm recommending it for you?
I guess.
Okay, so now we're going to jump into prepare that information for Mark and give you some background information on that. So looking again at our cumulative rates of respiratory viruses that are associated by hospitalization by age group. So we're seeing here cumulative respiratory rates associated with hospitalizations. This is all 18 and plus. And this was from 2024 October, so last October through April of 2025. You're seeing that overall, quite a big, cumulative. There's that these infections are associated with a significant number of hospitalizations. However, looking at that blue line there, the second highest line is our flu. So influenza was associated for adults 18 and older, was associated with the highest number of hospitalizations of the respiratory infections when we're looking at influenza, RSV, and COVID-19. And also looking at the rates of those viruses that are associated with hospitalizations by age group. So again, that, 18 to 49, you're seeing depending upon the year. So a little bit higher with COVID, but that's gone down. COVID's actually gone down a little bit, and we've seen that influenza kind of creeping back up. And then again, but then when we talk about our older adults, that COVID-19 is going to be a little bit higher than that influenza and that RSV when we're talking about our older adult population. Also important just to note that there's other things that, besides the respiratory infection itself of influenza, there's also other potential complications that are associated with influenza. And this is a study that was published, in 2024. So it's a more recent study that's actually looking at cardiovascular events associated with an influenza infection. And so adults are 6 times more likely to have a heart attack the week after being diagnosed with influenza. They're also 2 times that risk of having any sort of an acute cardiovascular event, even after mild infection. And 12% of adults with influenza or that have had flu also have an acute cardiac event. And of those, 30% were admitted to the ICU and 7% died. And so what we're seeing here is that there is that association with, and still not, quite under, quite positive as to where this is coming from, but it is also important to note that cardiovascular events are associated with an influenza attack, and studies are ongoing as to the etiology of this and the underlying cause of that. So also for influenza in adults, this is, I think, a really good reminder that, it's although that we typically think about the influenza vaccine, it's usually our children and our older adults that are the most vulnerable from complications overall. When we see those years that have the most severe form of influenza, that it's usually those years that have the most infectious strains, such as those that were seen in the 1918 world pandemic. It's actually the young and healthy adults that are most highly affected with that are it's deadly for those individuals. And so most cases, death was associated with severe flu strains. When we're talking about those again, those severe flu strains, it's usually seen in our younger adults that are otherwise usually healthy. So I think that's important to note that although when we talk about blanket, it's usually the young and usually the old, but there are those times when we have those really virulent strains that those are the times that our young healthy adults are the most affected. And we also know that that our influenza and our vaccines work. So when those that have received a flu vaccine usually have a 26% decreased risk of heart attacks, 33% decreased risk of cardiovascular deaths, and 82% decrease in risk of ICU admission. So again, those the benefits sometimes are more than just preventing particular, just, that acute respiratory infection that we sometimes just think of as the flu. So we'll go back to our case now. All right, so the flu shot isn't a perfect shield, but it does reduce how severe the illness can get. Even if you still catch the virus, you're less likely to end up with complications or miss as much work.
Yeah, but it feels like whenever I don't get the shot, I either don't catch the flu or it's super mild. I honestly think I get the flu from the shot itself.
That's definitely a common concern, and it can be frustrating when it feels like you're doing the right thing and still end up getting sick. I can assure you, though, that the flu shot cannot make you sick, since the shot contains a killed or weakened version of the virus that can't cause infection. There are some common side effects from the vaccine, like muscle aches, fever, headache, or fatigue, that sometimes can make it feel like the shot made you sick. I also do think that it's worth it to prevent severe influenza and reduce the spread of flu as much as we can.
I don't know. I'm not anti-vax or anything, but I just don't see myself getting sick enough to the point that would make the shot worth it.
It's definitely your call. I know the flu doesn't seem so bad, but I've heard of some really sad cases of perfectly healthy individuals who have gotten very ill from the flu. It also helps protect people around you, like older family or kids or anyone that might have a weakened immune system. I'm not here to pressure you, but I do want to make sure that all of your concerns are being addressed before you make a decision.
I appreciate that. I think I'm just gonna stick with my meds today, but I'll be back if I change my mind.
Of course, always feel free to stop by or call with any questions. And so, there again, this is an example of where the individual did not take our recommendation, but we still maintained that relationship and that positive relationship with them, and, kind of opening up that door for potential future discussions with them. All right. And so for our last knowledge check question, we are going to have a select all that apply. So which of the following vaccines are recommended for adults annually? A, shingles, B, RSV, C, COVID-19, and D, influenza. Again, you don't have to put anything in the chat or answer anything, but we'll just, if you want to think about that answer. And then, of course, C and D are the answer. So COVID-19, influenza. Right now, the shingles again is that 2-dose series, and then RSV is just that 1 dose at this time.
Wonderful. Thank you, Dr. Skoy, for that incredible presentation. We did have one question in the chat that I thought would be really great to address here. Um, so let's see. So if we had an adult age 55 who was at high risk for RSV, would you still give them the RSV vaccine now, even though the ACIP recommendations have not been accepted by the CDC yet?
Yeah, that's a really great question. So, just note that when a vaccine has been approved, so as long as it's been approved by the FDA, you're not giving a vaccination off label. But just note that if it has not yet been implemented or accepted by the CDC, your biggest issue will be the insurance or the reimbursement for that. So it would be a good idea to check with the individual's insurance, because the vaccines themselves can be quite costly, to see if they can either cover that vaccine or if their insurance could provide for it. So they're again noting that the vaccine is available and it's approved by the FDA, meaning that you could technically, it's still on label by FDA standard to give the vaccine, but until it's actually approved and implemented by the CDC, there usually is not coverage from the individual's insurance companies to pay for the vaccine. So that's a great question. I get that a lot.
Awesome. And I know we're over time, but uh, if anybody's willing to stay, I just think this is kind of a great wrap-up question here. So, vaccine hesitancy is growing every day. Any additional recommendations or tips for practice that you have?
Yeah, I think the more we talk about vaccines and the more we have it as part of our routine encounters with our patients, the better. And so it should be something that I think that patients should almost be expecting, whether they're going to the pharmacy or whether they're going to the clinic or they're going for a sports physical or whatever appointment it might be, that their healthcare provider is going to be discussing vaccines with them. It should never be a surprise or something that's being caught off guard. And I also think that the more comfortable and the more conversations we have with patients using that a presumptive approach and then potentially motivational interviewing, it's just like anything, that's the more comfortable we're going to get with it. And I think we're going to be seeing greater results as we continue to do that. So that would be my thoughts and advice.
Wonderful. Well, thank you so much for your time today, and thank you everyone for joining. We hope to see you at our next webinar.
Thank you for watching the recording of Adult Vaccine Conversations, Addressing Common Concerns. This session was presented by Dr. Elizabeth Skoy on May 15th, 2025. For those seeking CPE credit for watching this webinar, and for clarification, this is only for pharmacists and pharmacy technicians, please follow the details on the screen.